Today we're going to talk a little bit about breast cancer. As Charlotte mentioned, we're not just a breast center. I pretty much named it MedX Imaging and Ease Breast Center for two reasons. One is a lot of the radiology centers around here, they do have MRI, CT, ultrasound. They have all the 9 yards. They even have mammo. But they don't have a facility where you can actually get your biopsies done once they find out you've got a finding there. Typically you'll have to go somewhere else, and that's what's happening. I'm getting women coming from different facilities, and I'm having to do their biopsies. And really, once you get connected with your doctor, I really think you should stick with that doctor. I like to start a case and finish a case. I don't like to just diagnose and say, ma'am, you've got a lesion there, see ya, go find another facility. That's what's happening. And so, and I think that's an advantage. Once you're done with the screen at our center, we typically go through, if you find a finding, we call you back, I'm there. I will discuss your finding, I'll show you what needs to be done next, and we get you mentally prepared for the next step. Okay, that's the unique part about it. It takes about 48 to 72 hours for a path report. Once that comes in, we give you the information, and then we help navigate you to the next level. Okay, so everything's set. Now the next stage is, what do I do? I've got breast cancer. And I worked at a cancer center for 5 years, and I learned a lot. I mean, I've diagnosed every cancer under the sun, so I don't just do mammo. But the next stage is staging. And staging is really important. It's figuring out, okay, I've got it in my breast, but do I have it in my liver? Do I have it in my brain? Where else could it possibly be? So a lot of the doctors that I've actually aligned myself with, many of them really prefer that I just take over it. So we will then order the next step, which is the CT head, chest, abdomen, pelvis. We look for any disease elsewhere, and we package it up. At the center, the only thing I couldn't do was PET scan there, and I've got PET training. When PET first started here, I was one of the first PET expert readers in the area. And I did it on the job. I was lucky enough to work at a center like this where they could order these kind of studies. So hopefully one day that'll be my goal, to put that in and make it a one-stop shop completely for these people, for all types of cancer, and then send you off to the next level, which is your oncologist and your surgeon. Believe me, that's such a big, at first you don't understand how important that is until you have to start moving around from one place to another. If anyone in this room has breast cancer and has gone through it, and when you finish getting the diagnosis, you go to your oncologist. Oncologist says, well, ma'am, you need to go back and get a CT. Well, you need to do this and that. It's frustrating. So we like to put that all together, so when you go and you sit with your oncologist, you say, okay, here it is, here's my results. It's in my liver, it's over here. And he can start the process quick. There's no waiting time. Okay, so it's not just for this. We've diagnosed bladder cancers over here, we've diagnosed other things, we've staged them, and we send them off. And they've been very pleased with that, because the process goes quicker and faster. So that's the MedX portion of it. The Eves portion, I had a hard time deciding how to name it. I just want to give this because it's really close to my heart. I thought about it for a long time. I said, when kids, when they fall, they get hurt, who do they run to? They run to their mother. And I thought, what better name to give it other than Eves, because Eve is the mother of all mothers. Hence the name Eves, just so that you can remember it easily. Okay, but anyway, so this year, statistically speaking, about 200,000 women will be diagnosed with breast cancer. And of those, about 40,000 will die of breast cancer. And those are really important figures for all of us to think about. It's second to lung cancer. So, it's very important that breast awareness is out there, early detection is important, and knowing what to feel. And today I brought a little device here. It has 3 separate breasts, and in it there's pieces that you'll feel. Fibrocystic change, which is what a lot of women have, the lumpy, bumpy breast, and what to feel when it feels abnormal. You should look for a marble-sized finding. And at the end of this lecture, I hope all of you come up here and I'll help you out so that you know what to feel. Because I feel it's a little unjust, because I've given these lectures in the past. I've talked about how to give a breast exam. But one thing is, these women, they go home, they do their exams, they come back, and then they're laying on my table. And this happened just 3 weeks ago. One of my good friends came in, and she was diagnosed with stage 3 breast cancer. She had no idea. As she's laying on the table, I already knew, just looking at the mammogram, I knew it was bad news. On ultrasound, it was horrible, but she kept going over her breast. I said, go over it again for me. And I realized she never really learned how to do a breast exam. She just learned, okay, you go around, you go up and down, you do this and that, but what do I feel? And that's why I went out of my way to buy this little thing here, which I think you all really appreciate when you're done. And the key is to feel for nodules, not just the lumpy, bumpy breast. When do you do these exams? A lot of times doctors don't tell you. You should do it 1 week after your periods. If you're postmenopausal, the first of the month or the last of the month, so you remember it. Mammography in conjunction with ultrasound increases our likelihood of finding cancers, but with the self-exam, you would be amazed that when women come up to me, and this has happened, where they feel a little pea-sized thing in their breast, that turns out to be their cancer. So I never underestimate when you come to me and you say, I feel something there. We will take care of it. We will look at it and we'll investigate it. So don't underestimate that that little pea could be something that could turn out to be horrendous for down the road. Early detection is key because caring for the patient early on costs much less than finding somebody in stage 3 and stage 4. Okay? So I'm sort of going off topic here. I wanted to make this a little interactive with everybody. Does anyone know the difference between a screen and a diagnostic mammogram? A screening. Okay. Screening mammograms basically are, you come in, I have no symptoms, I'm getting my yearly mammogram, and I'm following what I'm supposed to do. That's a screen. A diagnostic means you've got some symptoms. Okay, you know you've got some symptoms, so you're automatically now going to be put into another category when you come in. I mean, somebody has to look at your breast, feel your breast, and do the whole 9 yards. That's a diagnostic. Anybody here have any ideas of some sort of issues that can occur with the breast? No? Any issues? Like nipple discharge? Anybody have any other ideas? Scar tissue, thickening? Dimpling. Anything else? A couple of things that we used to tell patients was that if you feel pain, it was an okay sign. It's probably not cancer. It's probably inflammation, trauma, whatnot. That's no longer true. Now, if you feel that pain and it's nonstop, it doesn't go away, that could be a very serious situation. And that may be an underlying cancer in there, so make sure you get that checked out. Dimpling is key. When you look for dimpling, you sort of bend over, look at your breasts, and see if there's any dimpling, anything being pushed inward. Nipple retraction, bloody discharge, scaling around the nipple, and it's not stopping, or it's oozing. These are things that you need to be very cautious about and come in and have yourself checked out by your primary care and go to the next level. Okay? Let's see. Oh yeah, one more thing I forgot. Make sure you also check your armpits. Another sign of breast cancer might be a big lymph node. And you would be shocked to see that some people don't even, I give you my girlfriend's example. She had a 3-centimeter lymph node. It was gigantic. And it was underneath her armpit, but it was way deep. And you need to go deep in, you need to feel. And keep an eye on these things. Alright? Another statistic. We always talk about that 1 out of 8 women will get breast cancer. That statistic really is valid. It's based on women living up to at least 85 years of age. Typically, most women don't live till they're 85. So the actual number really is, but it's there. So the good news is when you get called in for a follow-up, 1 out of 12 may have cancer, but there's that 11 out of 12 that don't. So a lot of times these findings do turn out to be benign, which is in our favor, which is good. But you need to have that doctor find some lesion, and it's really hard sometimes. It can be indeterminate. These solid lesions, they can fool you. So we always try to make sure. I can't tell you for sure, but the way I explain it to patients is we're reading shadows. And those shadows can create ugly pictures, and they can also create pretty pictures. And sometimes those pretty pictures can fool us too. I had a lesion that, she was an MS patient when I was at the VA. It was pretty scary. I thought it was just a little cyst, but it was just a little nodularity around the edge. And it prompted me, well, she was an MS patient, she's in a wheelchair. I just felt bad. I said, let me just aspirate it for her, and just get rid of it. I really am thankful I did that. That humbled me. That was my first day after finishing my fellowship. And I had this patient sitting in my office, and I took care of it. And I went in, nothing came out. I went in with a bigger needle, thinking it's just sticky, gooky stuff. Nothing came out. At that point, I knew this was solid. It was a solid lesion, but it looked like a cyst. and took a specimen, took some biopsies out. It turned out to be a mucinous carcinoma. So these are scary lesions, and mammography is not easy. The way I say it to people, it's like a cloud. Every picture that comes through is like a cloud. And each cloud that you see, you have to adapt to it and figure out this is her normal anatomy, her normal breast picture. And I have to keep that in my brain as I look through each image. So a lot of people don't like to read mammography for that reason. So, you know, you want to go to a place where people enjoy reading it, they have good statistics, they have good numbers. Okay? Let me ask you, I'm going to jump into myths of radiology, of breast cancer, just in general. I'm going to ask you guys, if you have no history of breast cancer, a lot of women think they don't need to worry about it. Is that true or false? And I want to hear, raise the hands. False? Okay, that's correct. That is correct. 80% of the women that come to our office, or just in general, 80% of women that get breast cancer do not have a history of breast cancer. 80%. Okay, and I'm going to go into this. Is really important because there's a new law out there called the Henda's Law. And Henda's Law refers to the density of the breast. And there's several states out there that are now mandating that we discuss breast density. Where I was trained here, we always included that in our report. So for me, it was a no-brainer. But one of the questions I used to ask my mentors is, well, geez, you know, I mean, I've got a dense breast. I'm giving her, we give these categories. Category 1 and 2 is usually benign. You pass, you move forward. And it goes up to 5. 3, 4s, and 5s we work up. Well, how do you know that there's nothing behind there? I'd always ask him. He said, well, we're done. We wouldn't get into it. Well, now with this new law, it actually gives you an opportunity to get to the next step, which is a breast MRI. However, there's a little disclaimer in that little Henda's Law. So when you go home, look it up. It's called HENDA, Henda's Law. That you have to have a family history of breast cancer. And that really, I mean, it really bothers me because when I'm sitting there and I look at a dense breast, and this woman may or may not have a history of breast cancer. Let's say, I'm just going to point these two ladies. This is patient A, patient B. Both of them have dense breast. One has a family history, one doesn't. Why would the law only allow her to have it? Because she has a family history. When 80% of the women that get breast cancer have no family history. That's my question. And it's really hard for me to fight these insurances and ask them this question because they're just stuck on their little, you know, yeah, that's it. And it's really hard. So a lot of times I tell patients, take it into your own hands, call your insurance company, talk to them and discuss your concern, you know. And I think every woman should have that right. It shouldn't just be limited to only those with, you know, family history. If I didn't have symptoms, I don't need a mammogram. Is that correct? Yeah. Breast cancer is just, it can be silent, just like every other cancer. They're silent killers, you know. You don't know you have it until you actually go get screened, do the right testing that you need to do, and do your yearly mammogram. There was recently an article that was published and put on the news. You shouldn't do it until you hit 50 or, you know, every 2 years, something to that effect. And don't even do breast exams on top of that. I thought that was ridiculous, you know. And did anyone listen to NPR this morning? No? On NPR, ironically, they were talking about younger women under 40 that were being detected more and more frequently with breast cancer. And when we opened the center, a 37-year-old walked into my facility, and it was like the second week, and said, do you think I should get a mammogram? And I thought, well, you know, at 35 you can start, and I would say every 2 years after that, and then at 40, once a year. I said, you know, if you feel you have symptoms, she's like, no, but I just like to get one. It's not harmful. I said, come on down. We did her exam. We found 2 breast cancers in the same breast. And they looked like calcifications. We didn't see a mass. Those calcs, we took them out, and those were her.
But by the time she would have waited until she was older, they would have been
way bigger. And it was just fortuitous that she walked in, you know. And a lot of times younger women have more aggressive cancers than the women who are 50, 60, and beyond. Younger women just, it's horrible. I mean, it spreads quicker, and it's just more vicious of a tumor, you know, from my experience. So that's why, you know, do your monthly exams. They're very important. I had one normal mammo, so I don't need another one. Is that true or false? False. False. So again, the key I'm trying to make a point out of is early detection is very important. Don't let those mammograms go. Make sure you get them done yearly. Having yearly mammograms increases my risk for breast cancer due to too much radiation. Oh, who says false? Raise your hand. And who says true? Nobody. Okay, good. The amount of radiation, I get this asked a lot by patients. How much radiation am I getting? And it's hard to explain how much radiation because we talk in rads and nobody understands what that means. A lot of times I tell patients you get more radiation when you fly in a plane than you do getting this. I looked up some other analogies, and another one would be sitting out. One mammogram is equal to getting the amount of radiation you get sitting in the sun for 2 hours. So you know, it's really not that much, or even equated to your dental exam. When you get a dental exam, it's equal to or less than what you get when you get a dental exam. But we never really ask, you know, if I'm getting a dental exam, I'm getting too much radiation. Radiation in and of itself, you know, when that beam comes out, it creates a scatter. And that scatter, it just goes all over the place. Even when you're in your dentist's office, they're scattered. And then, you know, I thought about this when I was reading this one. Just off the topic, when we go through those scanners at the airport, I haven't had time to look that up, but I always wondered how much radiation we're getting from that. You know, because it does the whole body. You know, and yet women don't stop and say, hold on.
Well, since we've got some really great input, will you discuss for us women over 50 the implications of like soy-based products or hormone supplementation and breast cancer?
Okay, that's an interesting topic. Let me talk about the younger women, and I'll bring it into perspective as to what I listened to on NPR. One of the reasons they're connoting the increased cause of these cancers is basically estrogen. Estrogen fuels the cancer, you know? So that is something that I think I know where you're going toward. Hormones, hormones is a big thing that's happening right now, left and right. I don't know too much about bioidentical hormones. I don't know too much about, you know, is it safer, exogenous or not. I've gone to a couple lectures and these are people who prescribe it and they say it's okay. But personally, I'm not sure. I don't know the answer to that, but I do know that estrogen in and of itself does fuel breast cancer. So if you're taking bioidentical hormones, make sure you get your mammograms done at least yearly. You know, don't omit them. That's all I can say.
Is there any correlation with soy?
I don't think there is.
Soy, you should avoid it, or you should...
I'll have to read up on that because I've not heard about soy. I've not heard about soy increasing your risk. Is that what you heard?
My husband was talking about it the other day.
Soy?
Yeah.
Okay.
We're at Starbucks. Somebody was talking about it.
That's
There's a
new.
Starbucks in Southlake.
Okay, that's new for me.
It was weird. I was like looking at it like, soy? Like, it's supposed to be good for you, but...
No, I don't know about soy, but I will get back to you on that one. I'll look it up. Okay, so that's right. Let's go back to. I'm not going to breastfeed because it increases my risk for breast cancer. I'm not gonna breastfeed. Yeah. It's actually the contrary. It's protective, because estrogen fuels it. When you're, when you're on your, when you're breastfeeding, it reduces your estrogen levels are low. You're not having a period.
Yeah, because they were born to breastfeed, right? Yeah, oh, it's school there. Go with the
So does mammo detect all cancers? Mammography detects all cancers, yes or no? No, it doesn't. There's no exam out there that's 100%. Mammography, like I said, in conjunction with ultrasound, increases our chance of finding a tumor with an exam, breast exam. or that done by your doctor increases it further. If we add MRI, we have an even more sensitive exam. MRI has its pluses and negatives. MRI is very sensitive, but it's not very specific. Unless we see a really fungating, spiculated lesion, yeah, I mean, we could have seen that on MRI, I mean, on mammogram or on ultrasound. But it can pick up tiny little things that can mimic tumors, and it's very complicated, but it is very sensitive. Women that are doing mammograms, one of the things this is a part of the exam that I'm going to where you know how you do it. You can go in a radial pattern, you can go in a round pattern, or you can go up and down your breast. Make sure you use your tips of your fingers, go nice and deep, and make sure you go around in nice little circles. Typically I tell women do it in the shower, you know, with the soap on, and make sure you do it, again, once a month if you can. I also miss mine from time to time. The key to surviving basically for breast cancer is early diagnosis, and I can't stress that enough. And empower yourselves by also knowing that, you know, you don't need to go to your doctor. I know a lot of women right now are going through a lot of families are going through a lot of issues right now in this economy. One of the things is they're not getting their exams. They're just not getting anything done. We have women come to my door and you know they're just like, we can't even afford it. You know, so I thought, well, wait a minute, how much are these hospitals charging? And I'm willing to really astronomical. I mean, I'm actually a physician. I can tell you right now, everywhere I've worked, I've never known the pricing of things. I never did. I always worked for somebody, and I never really asked. I just thought it's a given. People come to get it done. You have insurance, but it can take a toll on people. We actually decided to give $100 mammograms to women that are uninsured, help them out to make it easy for them. There's some women who haven't had it for 3-4 years. We're very grateful for that. So we took care of them. Another issue that I have with hospitals is we had another female come in. She had a really bad knee, and she was limping into my office. And the girls at the front desk saw her, and I mean, we were shocked. She had an order for MRI too, but it was scheduled somewhere else. But she couldn't get into the center because they had such an overload. The doctor said, well, just get your x-ray done. He didn't care where she went for that, but he cared where she went for this. And so she came over and she said, well, you know, I got confused. Is it Eves or is it MedX? We said it's both, and we have everything. She asked the price, and the price was in the low hundreds. And she was able to do not only her knee, her shoulder, but her opposite knee too. And still had money left over. Now, one MRI for her knee at the hospital is about $3,000 to $4,000 for just one. I mean, and I couldn't believe it. I was in shock myself. So I think, you know, as doctors, we really need to, you know, look at people from our own perspective. I mean, I personally would want to do a $3,000 to $4,000 MRI. I probably would sit on it too. And it's just too much money. I just don't think it's spent properly. I think, you know, the more, I mean, and these kind of mamas and papa shops that we're doing, there's a lot of doctors out there that really want to do medicine, and that's it. They really want to take care of patients. A lot of them that have aligned with me, I mean, they send my way. They know we take care of them. We want to provide 3 things: quality, we want to provide service, and comfort for our patients. And I think that's really important, and not just a center where we charge less, but the environment should be there. The environment should be beautiful. People should want to come to you. And as long as you keep that quality and service, I think, you know, you will succeed. So, important. I mean, it's something that I thought I'd put on the side out there that it bothered me that, you know, that she went to different places and, you know, she's limping and couldn't get that done. But anyhow, that was on the side. So, any questions? I know you all want to eat. I wanted to keep it kind of simple and, you know, easy going for y'all. Any questions? None? Yes, go ahead.
Do you ever do just ultrasound for early detection or screening?
Well, mammography right now is the gold standard, okay, but we do ultrasound on young women. And the reason why we do it, young meaning like 18, 20, I mean, if you're 25 and up, I will still, push you through the scanner. It's so minimal. But if I miss those counts, which is something I can't see on ultrasound or MR, I've done an injustice to you. So yes, we do ultrasound screens, but we do them on younger women. Some women, they don't want the exam center. There's another controversial subject out there with thermography. I don't know how to read those myself because we've never really read those. That's something that I don't know any MD that has gone through training for. But it's out there. I don't know how many of you all have had thermograms. Yeah. Thermogram is basically, it detects heat. And my understanding is that it detects heat underneath the skin, so it only has a certain amount of tissue that it's detecting. Whereas a mammogram, you're looking through the whole breast. Whereas with MRI, you're looking through the whole breast. And whereas with ultrasound, you're looking through the whole breast. So for me, I feel like if I wanted my exam, I wanted to go through the whole breast. Another question, another thing, should it hurt when they do the mammogram? It really shouldn't hurt. If you know that you've got fibrocystic change, you know you've got breasts that are really tender a lot of times, most of the time, make sure you take a Motrin before you go to your doctor. Before you go. Take a Motrin afterwards too. But it shouldn't hurt. If they're trained properly, the girls that I chose, I sat with them, we go through everything, I watched them, and I had her do mine. And if she can't pass that test, she can't stay. It should not hurt. But some people are more prone with the fibrocystic changes and all that. But then I say make sure you take your pill. Well, another thing I want to tell you all, but as far as MRI, because we do breast MR too and everything else and all the whole body. There's a new thing. We have short bore and we have long bore. I'm very claustrophobic. I mean, you can put me through an I want out. So with these licenses that I had, I actually had a great opportunity to go around the whole United States actually and look at different centers too when I worked there. So I took a little bit of everybody's, look from some centers. One thing I liked about this place was they had windows at the end. And the cues that I got from the sun's rays and so forth, natural cues, I was able to go through that scanner. And I had no problems. A little bit of fear, but I finally went through it. I always tell people that if you have that fear, still take your Xanax with you, talk to your doctor, maybe the tranquilizer, whatever you need. It works quick. You take it, try your first round without it. If you ever have to come back again, then you can try it without. We've had patients that come through, literally, stand right there and say, I'm not going in there. We had one lady, she needed 3 MRIs. She said, I'm not going in there. I said, come on, let's try it out. I told her about mine, and I got her to finish all 3 in one day. She never came out of that scanner. She did it, and she was fine. The cues of the sunlight really made an impact on her. So that's important too. So, learn about your center. Find out, oh, the other thing is you don't need a doctor's what do you call referral? Yeah, that saves some time. Another thing, doctor referral, shop around. Make sure you ask your prices. You have the right to choose. That was it. Your doctor might tell you to go to a certain place. Call that place, especially when it's a hospital. And when you hear $3,000 versus a $400 or $500, I don't think anyone will think twice. Where they're going to go. And let your doctor know you have a right to choose. They're going to give you something that says, here, go here. Somehow along the way, I just remember with my kids, when I was having my babies, I got a prescription. Surprise, you're pregnant. Now you need to go see an OB-GYN. And I went out of my way and I found my own OB-GYN. I think that's the same thing you need to start doing with radiology too. Today I wanted to put a face to radiology. When you come to our center, how many of y'all know your radiologist? I wanted to put a face to radiology. It's something that it's long overdue. The way I look at it is, we are the doctors. I worked for an oncology group. If I saw the cancer and it got bigger, it changed the way your planning would occur, what would be the next step. If it shrunk, it changed the way things worked out for you. I remember one day when I was sitting down in that little office, and I was all by myself. We had about 7 or 8 doctors on the top floor. We're always feeding cases. And I would go over everything. I would talk to my patients. one day this lady said, "Oh, Dr. So-and-so, he's so wonderful, he found my cancer." And you know, I must have been having a bad day that day because I was like, "Excuse me, you found what?" And he took the whole credit for it too. So I asked the girls to go get me his jacket. That was in the day when we had jackets. And I would circle everything with a wax pencil. And apparently she says he's so fast. When he opens that, he can find it real quickly, you know. And the CT scan, I said, "Really?" So I brought it in, I had her sit, and I showed her and I demonstrated how quickly he does it. Because when he looks for the wax pencil. And I pulled it up. I said, "This is what our radiologist did. This is what I did for you," you know. Not that I care for the, anything and all that, but to make them understand that, you know, we're not technicians. We are really MDs. And that we are out there, we are sitting there and doing this work. Pushing through. So, you know, take it into your hands, let your doctors know, you know, if you want to go somewhere else, you can go. And another thing, we're going green. So what we do is when you come to our center, we'll sign a release, we call the facilities, and we ask them to put it on a disc. And the first time, it might take a little while before you get your results, maybe a week or 2 weeks, because it takes some time for them to send everything over. But after that, it's within a day or two. You know, everything should be out. Your doctor should have the results. And if it's positive, you get a call. You get a call and they'll be coming back.
And do you recommend doctors?
We can recommend, we suggest, you know, again, I always keep that offer to get the right in your hands. And everybody, you know, it's getting to know your doctor. You might not like somebody I sent you to, but I'll give you a couple of options. You know, for example, if you have breast cancer, this has happened. I've gotten to meet quite a few doctors. I actually go out in the market and I meet my doctor. If my patient tells me this is a great doctor, I want to go out and meet that person too. And I want to see what kind of facility it is, so I know where I'm sending you to as well. And so when I send you, I know where I'm sending you. So yeah, I do make referrals, but I leave it to you to make the final decision. Yes, anything else? Yes?
Are you in particular preferred provider network or?
We take all insurances, all the insurances. So,
Even VA?
Can we get some
Is it harder to find a tumor? You know when you have the silicone implants, it does get in the way. I have to admit, it does get in the way. But, you know, in the hands of a good technician, you pull out enough breast tissue, it's not that hard, yeah. But it does get in the way. If you have saline, it's a little bit more readable.
I mean, I had silicone
Mm-hmm.
and I'm 5 years. And they recommend that you have an MRI. Is that?
Yeah, we do it. I've talked to some of the plastic surgeons in the area. Some of them will get their mammograms done before they put the implants in. Some of them won't. I'm going to go to the MR too. And I think that's really important because you want to find out, do you have cancer first before you put an implant in? But not all of them do it. I mean, 2 out of probably 10 of them do that.
I mean, I had my mammogram. I had to have a mammogram beforehand.
But not all of them do that. Now the next level is, do I have, I thought the recommendation when I read it last was after 2 years, but 5 years is fine too, and I would recommend doing it. I've seen some interesting looking implants, you know, since we started, yeah. And it's because they've never had a mammogram after they got their implants.
And I have. I've had an ultrasound and I haven't had an MRI.
Yeah. I mean, we would do it just to check to see if her implants are taxed, and 5 years is okay. You don't have to do it for 2. 5 years is fine too. Yeah. Any other questions? All right. Well, thank you for your time, and thank you for inviting us. Thank you so much.
You know, a good referral for Dr. Kahn would also be your OBs, because they refer for mammograms all the time. What else?
You know, any profession can actually send to us. Because like I said, we do CT, MR, ultrasound, you
Yeah,
name it.
sports therapy, sports therapists.
You're not even the
Everyone
teachers.
would be.
We're trying to get the teachers too to come out because they, you know, them and the sports teams. I was shocked. We had a kid from Southlake come. He was a football player, and I had to get him. I was talking to a man. It was like so we do them all, you know, the whole 9 years. So talk to them, spread the word, and really appreciate your business. All right? Thank you.
Ladies, thank you for coming out today. Does anyone have any announcements personally or professionally for your business that you want to share or announce or anything like that? If you do, this is a great opportunity if you have any events coming up.